The surgical simulation lab sat empty at 5:47 in the morning. Nothing but the hum of fluorescent lights and the quiet, rhythmic movements of Dr. Marcus Thompson's hands. He stood at the training station, dark fingers moving through synthetic tissue with a precision that went beyond what any medical school could teach. His close-cropped hair caught the harsh overhead light. His eyes? They never left the practice incision he was closing with interrupted mattress sutures. Dr. Richard Brennan entered without a sound. The chief of cardiothoracic surgery at Boston General Medical Center moved like he owned the place, which in a way he did. 30 years. That's how long his name had meant surgical excellence. Silver hair perfectly styled, white coat immaculate even at this ungodly hour, gold-rimmed glasses catching the light as he paused in the doorway. "You're here early for a first year." His voice sliced through the silence. "Hoping extra practice will make up for lack of natural talent?" Marcus's hands didn't falter. He completed the stitch, tied it off with practiced efficiency. Only then did he look up. "Just preparing, Dr. Brennan." Soft voice, almost deferential, but something in his posture didn't quite match the submissiveness of his words. Spine too straight, shoulders too squared. Brennan walked closer, watching those hands move through the next suture, eyes narrowed slightly. "You're using military-style interrupted mattress technique. That's not what we teach here." Marcus's fingers paused, maybe half a second, then continued their work. "I study various approaches, sir. Different techniques for different situations." Brennan picked up the file from the nearby desk. He'd already read it 3 times since approving the residency application 6 weeks ago. Stanford undergraduate, top of his class, excellent recommendations. He looked up, something calculating in his gaze. "Everything looks perfect on paper, Dr. Thompson. We'll see how you handle actual patients." "I'm ready whenever you need me." Marcus finished the final suture and stepped back from the training model. The incision was closed with geometric precision, each stitch exactly the same distance from the next. Brennan examined the work. His expression gave nothing away. "Report to OR prep at 7. You'll be observing today. First years observe. That's how we do things here." "Yes, sir." As Brennan turned to leave, Marcus rolled down the sleeve of his scrubs. Not quite fast enough. Brennan caught a glimpse of something dark on his right forearm. He paused at the door. "That tattoo? What is it?" Marcus's jaw tightened, almost imperceptibly. "Personal, Dr. Brennan. Visible tattoos aren't exactly professional in a surgical residency." He didn't wait for a response. Just let the door swing shut behind him. Marcus stood alone in the simulation lab, staring at the closed door. His right hand moved unconsciously to his left forearm, fingers tracing the outline of the caduceus with wings. It marked him as something other than what everyone here assumed he was. The sound of a helicopter passing overhead made his eyes close. 3 full seconds. And in that brief moment, he was somewhere else entirely. Somewhere with sand and blood and the constant thunder of rotors that meant life or death. The locker room was starting to fill with residents when Marcus arrived at 6:30. He changed quickly, eyes down, movements economical. The other first years chattered nervously about the day ahead, but he remained silent, methodically checking his pockets for the essentials every resident carried. Pen light, notepad, pen, trauma shears. Well. Dr. David Webb leaned against the lockers, his tall frame blocking the path. Still practicing basics. Some of us already graduated to real patients. His eyes held a mixture of amusement and something harder. David was a 3rd-year resident, son of 2 famous cardiac surgeons. He wore his pedigree like armor. Just being thorough. Marcus moved to step around him. "Thorough." David laughed. 2 other residents joined in. "You know what they call people who are too thorough in surgery? Slow. And slow gets people killed." Marcus met his gaze for a moment. Something in his eyes made David take a half step back before he caught himself. "I'll keep that in mind." In the scrub room adjacent to operating room 3, Nurse Patricia O'Connor was doing her morning inventory. At 52, Pat had seen more surgeries than most attendings would perform in their entire careers. Red-gray hair pulled back in a practical bun, hands moving with the automatic efficiency of 28 years in cardiac surgery. She'd been a nurse in the Gulf War before transitioning to civilian medicine. She had little patience for incompetence or ego. She looked up when Marcus entered to begin his pre-surgical scrub, even though, as an observer, it wasn't strictly necessary. The younger man's movements caught her attention immediately. The way he positioned himself at the sink, the angle of his elbows, the methodical progression from fingertips to forearms. Pat had seen that exact technique before, in field hospitals where every motion had to be perfect because there was no backup, no second chance. First day observing? Her Irish accent was still strong after 3 decades in America. Yes, ma'am. Marcus kept his eyes on his hands, counting the strokes automatically. You can drop the ma'am. This isn't the military. Pat watched his shoulders stiffen slightly. Or is it? Marcus looked up then, his dark eyes meeting Pat's green ones. I'm just a resident, Nurse O'Connor. Pat moved closer, drying her hands on a sterile towel. That tattoo on your arm, when you reached for the soap, your sleeve moved. She kept her voice low, aware that other staff were moving in and out of the scrub room. Medical Corps insignia, combat variant. I had one almost exactly like it before I had it removed. The water ran over Marcus's hands. For a moment, he didn't respond. Then quietly, you're mistaken. Am I? Pat studied his face. Because those sutures you were doing in the simulation lab this morning, I saw them through the window when I came in early. That's not civilian technique. That's what you use when you're working on someone in the back of a Humvee, and the road is so rough you can barely keep your footing. Marcus shut off the water and reached for a towel. With respect, Nurse O'Connor, I need to get to the OR. Pat nodded slowly. Fair enough. But if you ever want to talk, my office is on the 3rd floor. Sometimes it helps, talking to someone who's been there. The words hung in the air between them, heavy with shared understanding that neither could fully acknowledge. Marcus gave the briefest nod and pushed through the doors into the operating room, where Dr. Brennan was already positioned, examining X-rays on the light board. Dr. Thompson, you'll stand there. Brennan pointed to a spot well back from the table where he'd have a view but be completely out of the way. Today, you'll observe a routine valve replacement. Pay attention to every step. One day, if you prove yourself, you might be allowed to hold a retractor. The residence lounge at 10:15 a.m. was a study in exhausted ambition. 4 first years and 2 second years sprawled across worn couches, surgical masks hanging around their necks, coffee cups in various stages of emptiness scattered across the table. David Webb sat with his back against the armrest, holding court as usual. Did you see his face when Brennan told him he'd be observing for at least 6 months? He laughed, shaking his head. He looked like he wanted to argue but didn't have the guts. Who? Thompson? A second-year resident named Jennifer Park glanced toward the door as if Marcus might walk in. He's too quiet. I've barely heard him say 10 words since orientation. That's because he's probably been up all night memorizing surgical videos. David took a long sip of coffee. Textbook smart doesn't mean anything in an OR. When the pressure hits, he'll freeze like everyone else does their first time. I don't know. Another first-year, Lisa Chen, looked thoughtful. Did you see him in simulation yesterday? His suturing speed was insane. I've never seen anyone close an incision that fast. YouTube tutorials can teach you speed. David dismissed the observation with a wave. Doesn't mean he can handle a real patient, real blood, real consequences. Those sutures weren't just fast. Jennifer leaned forward. They were perfect. Every single one identical. That's not something you get from videos. That's muscle memory, hundreds of repetitions. Maybe he practiced on cadavers at Stanford. David stood, stretching. Either way, Brennan won't let him touch anything important for months. First years observe. That's the hierarchy. In his office on the 5th floor, Dr. Brennan sat across from Pat O'Connor, her personnel file open on his desk, though he wasn't really looking at it. The morning sun slanted through the blinds, casting shadows across his face. "You wanted to see me, Dr. Brennan?" He removed his glasses, cleaning them with a small cloth from his pocket. "Dr. Thompson, what's your read on him?" Pat considered the question carefully. "He's competent, very competent, more than any first year I've seen in 28 years here." "That's not what I asked." Brennan replaced his glasses, his sharp blue eyes focusing on her. "You were watching him in the scrub room this morning like you recognized something." "I did." Pat folded her hands in her lap. That tattoo on his forearm, Medical Corps insignia, combat variant, and his technique, the way he moves, the way he positions himself, that's military training. His file says Stanford Medical School, top 5% of his class. Nothing about military service. Brennan flipped through the pages again as if expecting new information to materialize. Maybe he didn't list it. Maybe it was before medical school. Pat paused. Or maybe it was instead of traditional residency. The military runs accelerated programs in combat zones, field hospitals where you learn fast or people die. That would make him what? A veteran pretending to be a first year? Brennan's tone was skeptical. Why would anyone do that? "I don't know, but I know what I saw. Those aren't civilian hands, Dr. Brennan." Before he could respond, his pager went off. He glanced at it, then stood. "We have a case. Harold Chen, 67, aortic valve stenosis, elective replacement, routine procedure. Webb will operate under my supervision." "And Thompson?" "Observing. Like I said, first years observe." Brennan headed for the door, then paused. "But keep watching him, Pat. If there's something he's hiding, I want to know what it is." At 11:23 a.m. on a Tuesday morning, Operating Room 3 was a controlled environment of steel and sterile precision. Harold Chen lay unconscious on the table, his chest prepped and draped, monitors displaying steady, vital signs. Dr. Brennan stood at the head of the table with David positioned for the primary incision. 2 surgical nurses flanked them, instruments ready. Pat monitored the equipment, and Marcus stood in his designated corner, far enough back to be out of the way, close enough to see everything. Scalpel. David's hand was steady as he made the initial incision, following the guidance Brennan provided in low, measured tones. Blood pressure is 142/88, heart rate holding at 76, everything nominal. Marcus watched the monitors more than the incision. His dark eyes moved between the EKG readout, the oxygen saturation levels, the arterial pressure waveform. Something about the rhythm bothered him. The ST segments weren't quite right. There was an irregularity buried in what looked like normal sinus rhythm. Something subtle that the monitoring software wasn't flagging because the overall pattern fell within acceptable parameters. "Dr. Brennan." His voice was quiet but clear. "The EKG pattern, the ST segment elevation in leads in 2, 3, and AVF. That's not just stenosis. There's underlying fibrillation." Brennan didn't look up from the surgical field. "Vitals are stable, Dr. Thompson. We proceed as planned." "With respect, sir, if we open without preparing for rhythm conversion, when the heart is manipulated during valve exposure, that underlying instability could trigger ventricular fibrillation." Marcus took a half step forward, then caught himself. "We should have antiarrhythmics ready and internal paddles on standby." Now Brennan did look up, his eyes cold above his surgical mask. "I've performed over 800 of these procedures. You've observed exactly 0. The vitals are stable. We proceed." "But the calcification pattern on the imaging suggests—" Marcus started. "Dr. Thompson." Brennan's voice cut like a blade. "You are here to observe and learn, not to question. If you cannot do that, you can leave." Marcus's hands clenched once at his sides, then relaxed. "Yes, sir." He stepped back to his corner. David resumed the procedure, his confidence growing as Brennan guided him through each step. Pat glanced at Marcus, saw the younger man's eyes locked on the monitors, his jaw tight. The nurse had seen that look before, on the faces of medics who knew something was about to go wrong but couldn't stop it. Retractor. David placed the instrument, exposing the surgical field. "We're ready for the sternal saw." "Proceed." Brennan watched critically as David made the cuts, spreading the ribs to access the heart itself. "Beautiful work, Dr. Webb. Clean, precise. This is how it's done." The monitors continued their steady beeping. Harold Chen's heart beat with mechanical regularity, unaware of the hands preparing to stop it, repair it, restart it. David reached for the next instrument, and then, exactly as Marcus had predicted, everything went wrong. The monitor's steady beeping transformed into a shrill, continuous alarm. The EKG trace on the screen dissolved from organized rhythm into the chaotic, disorganized waves of ventricular fibrillation. Harold Chen's heart, exposed in the surgical field, began to quiver uselessly instead of pumping blood. "V-fib!" Pat's voice cut through the sudden chaos. "Blood pressure dropping. 90 over 60. 80 over 55. David froze, his hands suspended above the open chest, his face going pale above his surgical mask. "Dr. Brennan, what should I—" "Step back, Webb." Brennan moved into position, his voice sharp and controlled. "External paddles, now. Get me 200 joules ready." Marcus didn't ask permission. He simply moved forward, his body shifting from observer to operator in a single fluid motion. His hands went to the instrument tray, selecting what he needed without hesitation. "Dr. Brennan, external defibrillation won't work. The chest is already open. We need internal cardioversion now." Brennan's hands hovered over the surgical field for perhaps 2 seconds, his mind calculating risks, protocols. The fact that a first-year resident was telling him how to save his patient. Then his training overrode his ego. Do it. Marcus's movements were like watching a different person emerge from inside the quiet, differential resident who had stood in the corner, his hands moved with absolute certainty. Scalpel. He extended the incision David had made, his fingers working with practiced speed, extending to 4th intercostal space for better access. "Internal paddles." Pat handed them over, her eyes wide but her movements automatic. "Charging to 10 joules." Marcus positioned the paddles on either side of the quivering heart. Clear. The first shock made Chen's body jerk slightly. The EKG trace remained chaotic. "Still in V-fib." Brennan's voice was tight. "Blood pressure 70 over 45. Amiodarone, 150 millim IV push." Marcus's voice was calm, almost detached, as if he'd done this 1,000 times before, which Pat was beginning to suspect he had. The medication went in. Marcus recharged the paddles. 20 joules this time. Clear. The second shock rippled through Harold Chen's exposed heart. For 3 seconds, that felt like 3 hours. Nothing changed. Then the monitor caught a single organized beat, then another. Rhythm converting. Pat's voice held something like awe. Sinus rhythm establishing there. Marcus's hands moved to suction, clearing blood from the surgical field. "I can see the valve clearly now." He paused, examining what the fibrillation crisis had revealed. "Dr. Brennan, the calcification is worse than the imaging showed. See here and here. The deposits extend into the annulus. We need aggressive debridement before we can place the replacement valve, or it won't seat properly." His fingers moved like a concert pianist performing a complex piece from memory, each motion precise and purposeful. He began the debridement without waiting for approval, removing calcified tissue with careful, deliberate strokes. Too aggressive, and he'd damage healthy tissue. Too cautious, and the new valve wouldn't function properly. David stood back, transfixed. Jennifer Park, who'd been called in to assist, stared at Marcus's hands. Even Brennan found himself simply watching, his role shifting from primary surgeon to witness. Small Richardson. Marcus's hand extended and the retractor appeared in it instantly. Now I need better visualization. Suction here. The anesthesiologist called out from his station. Heart rate stabilizing at 78, blood pressure rising 95/60, 105/65. Marcus worked in silence for the next 40 minutes, his hands moving through tissue with the kind of confidence that came from experience far beyond his supposed training. He debrided the decalcification, prepared the valve seat, positioned the replacement valve, and began suturing it into place with interrupted stitches that were absolutely identical, each one placed with geometric precision. Proline suture, 2 Nero. His voice was soft, almost meditative. Each stitch needs to be exactly the same tension. Too tight and you'll tear the tissue. Too loose and you'll get regurgitation. He placed 12 sutures in 8 minutes, each one perfect. Test the valve. Marcus stepped back slightly, allowing Brennan to examine his work. He did, checking every aspect with clinical precision. No regurgitation, perfect seating, excellent hemostasis. His voice was quiet, professional, but there was something else beneath it, something like recognition. Closing the pericardium. Marcus had already moved to the next step. Running stitch, 3-nil Vecral. His hands flew through the closing procedure, layers of tissue brought together with practiced efficiency, the kind of efficiency you didn't learn in simulation labs or from surgical videos, the kind that came from doing this in circumstances where speed mattered, where every second counted because there was another wounded patient waiting, and another after that. The clock on the wall showed 2:14 p.m., from the moment of ventricular fibrillation to complete valve replacement and closure had taken 87 minutes, a procedure that typically required 3 hours minimum. Brennan checked his watch, then looked at the monitors. All vitals stable, heart rhythm perfect. He turned to Marcus, who was removing his blood-stained gloves. "Where did you learn that technique, Dr. Thompson?" Marcus met his gaze steadily. "Training, sir." He dropped the gloves in the disposal bin. "I can scrub in for the 3 p.m. case if you need me." He walked out of the OR before anyone could respond, leaving behind a room full of people who were all thinking the same thing. That wasn't a first-year resident. That was someone with years of high-pressure surgical experience. The question was, where had he gotten it? And why was he pretending to be something he wasn't? Pat followed Marcus into the scrub room, where the younger man stood at the sink, methodically washing his hands with more force than necessary. His shoulders were rigid, his breathing controlled but slightly elevated. "That was incredible," Pat said quietly. Marcus didn't look up. "I did what needed to be done." "You saved his life." Pat moved closer. Brennan would have gone with external defibrillation. By the time he realized it wasn't working and switched to internal paddles, Chen would have been brain dead. Now Marcus did look up, and Pat saw something in his eyes that made her catch her breath. Exhaustion, old pain, the weight of too many impossible decisions. "I just want to help people, Nurse O'Connor, that's all. Can I do that without everyone questioning everything?" Before Pat could answer, the OR doors burst open and David Webb emerged, his face a mixture of shock and something else, something that looked like the first stirrings of respect. "How did you—" he started, then stopped. "I've been training for 3 years. I couldn't have done what you just did." Marcus dried his hands carefully. "Precisely. You would have figured it out. Dr. Brennan was right there to guide you." "No." David shook his head. He was about to do external defibrillation. You knew instantly what was needed. That kind of decision-making doesn't come from books. Marcus pulled his surgical cap off, his close-cropped hair revealed. "I study hard, Dr. Webb. Now, if you'll excuse me, I need to get ready for the next case." He left him standing there, staring after him, wondering who Marcus Thompson really was. The residence lounge at 3:45 p.m. was thick with tension and whispered speculation. 6 residents clustered around the coffee maker, their voices low but urgent. Word had spread through the surgical department faster than a code blue announcement. The first year, who nobody knew, had just performed an internal cardioversion and a complicated valve replacement while the chief of cardiothoracic surgery watched. I'm telling you, that wasn't luck. Jennifer Park set her coffee down hard enough to slosh liquid onto the table. I was in there. I handed him instruments. He didn't hesitate once. Not once. Every movement was exactly right. David sat in the corner, unusually quiet. He'd been replaying the surgery in his mind for the past hour, trying to reconcile what he'd witnessed with everything he thought he knew about surgical training. Maybe he's just really good at staying calm under pressure, Lisa Chen offered, though her tone suggested she didn't believe her own explanation. Nobody learns to suture like that from staying calm. Jennifer shook her head. Those interrupted mattress stitches. 12 of them, each one identical. That's not talent. That's hundreds, maybe thousands of repetitions. He had to have trained somewhere else. Another second-year resident, Michael Torres, leaned forward. Stanford doesn't teach that kind of speed. I did a rotation there. Their residents are good, but they're methodical, slow and perfect, not fast and perfect. David finally spoke up. He predicted the V-fib before it happened, called it out based on EKG patterns I couldn't even see. Brennan dismissed him, and then 30 seconds later, exactly what he said would happen did happen. So what are you saying? Lisa asked. That he's some kind of surgical prodigy who decided to hide his abilities? I'm saying he's had training. None of us have. David stood, walking to the window. And I want to know where. In his office, Dr. Brennan sat across from Pat O'Connor for the second time that day. The afternoon sun cast long shadows across his desk. His expression was troubled in a way that Pat had rarely seen in 30 years of working with him. You were right, he said without preamble, about the military training. Pat waited, knowing he had more to say. That internal cardioversion technique. Brennan removed his glasses, rubbing the bridge of his nose. I've seen it before, once, at a trauma conference. A military surgeon from a forward surgical team demonstrated it. Said it was standard protocol in combat zones where you don't have the luxury of time or proper equipment. And the way he moved, Pat added, like he'd done it under pressure before. Real pressure, not simulation pressure. He's 29 years old. Brennan put his glasses back on. If he went straight through medical school, graduated at what, 25 or 26? That's not enough time to get that kind of experience in civilian medicine. Unless it wasn't civilian medicine. Pat folded her hands in her lap. Unless he did military residency, accelerated program in a combat zone, 3 years instead of 5 or 6, but with trauma volume that most surgeons don't see in a lifetime. Before Brennan could respond, the overhead speaker crackled to life. Both of them froze at the words that followed. Trauma Alert Level 1, Mass Casualty Incident. Highway collision involving military convoy. Multiple critical casualties inbound. ETA 8 minutes. All available surgical staff report to emergency department immediately. This is not a drill. Repeat. Trauma Alert Level 1. Brennan was on his feet before the announcement finished. Let's go. The emergency department transformed into controlled chaos within 60 seconds. Trauma bays were cleared and prepped. Surgical teams assembled. Equipment rolled into position. The attending physicians coordinated, voices sharp and efficient, preparing for the unknown variables of mass trauma. Marcus emerged from the stairwell at a run, still in his surgical scrubs from the valve replacement. He paused just inside the ED, his eyes sweeping the scene with the kind of automatic assessment that came from muscle memory. 5 bays being prepped, 2 trauma teams, 1 cardiothoracic team, not enough for what was coming. He could hear it in the radio traffic, see it in the way the charge nurse was biting her lip. The radio on the wall crackled with updates from the ambulances. Primary transport, this is Medic 7. We have 5 critical patients. 2 were code blue in transit. Successful resuscitation but unstable. 3 with penetrating chest trauma from secondary explosions. Military transport truck T-boned by semi-truck at the intersection of 5th and Madison. Ammunition in the truck bed cooked off from the impact fire. Requesting all available trauma surgeons. Cardiothoracic specialty preferred. Brennan strode in, David and 2 other residents behind him. He began assigning positions immediately. Webb, you take Bay 1. Richardson, Bay 2. Torres, Bay 3. His eyes landed on Marcus. Thompson, you're observing in Bay 5. Least critical patient. Marcus opened his mouth as if to argue, then closed it. Yes, sir. The first ambulance arrived at 4:17 p.m. exactly. The bay doors crashed open and paramedics rushed in, wheeling a gurney carrying a young sergeant, maybe 23, his uniform torn and bloody. The paramedic at the head of the gurney was calling out vitals when he saw Marcus. He stopped so abruptly that the other paramedic almost ran into him. His eyes went wide behind his blood-spattered face shield. Wait! His voice was hoarse from smoke inhalation. Dr. Thompson! Major Thompson! Marcus felt his stomach drop. He knew that voice. Specialist Greg Morrison, who'd been a combat medic in Kandahar. He'd trained him himself, worked alongside him in conditions that still haunted his dreams. You're mistaken. His voice was steady, but his hands clenched at his sides. I'm just a resident here. But you... Morrison looked confused, his exhaustion making it hard to process the disconnect between what he was seeing and what he knew. Kandahar, 2021. You saved half my platoon when our convoy got hit. You're the one who taught me how to do chest decompressions under fire. Wrong person. Marcus stepped forward, his professional mask firmly in place. Where's your patient? What are his injuries? Morrison stared at him for another second, then shook his head as if trying to clear it. Maybe I'm more rattled than I thought. He refocused on his patient. Sergeant David Park, penetrating chest trauma, possible pneumothorax. Pat O'Connor stood 10 feet away, inventory clipboard forgotten in her hands. She'd heard every word, watched Marcus's face go carefully blank, seen the recognition in the paramedic's eyes. Bay 5, Marcus directed them, following the gurney. Let's get him stabilized. The second and third ambulances arrived in quick succession, the ED filled with controlled urgency, the sound of multiple traumas being assessed simultaneously. David in Bay 1 was dealing with abdominal trauma. Bay 2 had a head injury. Bay 3 had compound fractures. And in Bay 5, Marcus examined the sergeant who was supposed to be his least critical case. He placed his stethoscope on his chest, listened, moved it to another position, listened again. His face went very still. Respiratory rate 28. Decreased breath sounds on the left side. Tracheal deviation. He looked up at the trauma attending, Dr. Sarah Kim. This isn't minor chest contusion. This is tension pneumothorax. He's got maybe 3 minutes before his heart stops. Dr. Kim moved to confirm, her stethoscope already out. You're right. She looked around for a chest tube kit. We need to decompress now. I need a chest tube kit in Bay 5 now. Marcus raised his voice to be heard over the organized chaos. A nurse hesitated. Dr. Thompson, you need attending authorization for invasive procedures. He'll be dead in 3 minutes. Marcus's voice cut through the noise like a scalpel. Kit, now! Pat appeared at his elbow, the kit already in, her hands. Do it, doctor. Their eyes met for a fraction of a second, understanding passing between them. Then Marcus's training took over completely. His hands moved with absolute certainty. 5th intercostal space, mid-axillary line. He palpated the landmarks through the torn uniform, finding his position by touch. Betadine. Pat swabbed the area in 3 quick strokes. The sergeant's breathing was getting more labored, his lips beginning to show a faint blue tinge. His oxygen saturation was dropping on the monitor. 89%, 86%. Needle decompression first. Marcus took the large bore catheter from the kit. This will relieve the immediate pressure. He inserted the needle at a precise angle. The hiss of escaping air confirmed his diagnosis. The sergeant took a shuddering breath, his color already beginning to improve slightly. But that's temporary. Marcus was already prepping for the chest tube. We need definitive treatment. Scalpel. He made a small incision, then used blunt dissection to create a tract through the intercostal muscles. His fingers worked with practiced efficiency, feeling for the pleural space. There, chest tube. The tube slid in smoothly. More air rushed out, followed by some bloody fluid. The sergeant's oxygen saturation began climbing, 88%, 91%, 94%. Secure it. Marcus stepped back, allowing the nurse to suture the tube in place. Dr. Kim, he's going to need a chest X-ray to confirm placement, but he's stable now. Dr. Kim was staring at him with an expression that mixed professional appreciation with deep confusion. That was textbook battlefield procedure. Where did you learn that? Before Marcus could answer, a shout came from Bay 3. Code Blue! Patient's crashing! Marcus turned to see medical staff converging on Bay 3, where a soldier with penetrating chest trauma was deteriorating rapidly. The monitors showed blood pressure plummeting, heart rate climbing into dangerous tachycardia. Pericardial tamponade. The attending physician, Dr. James Morrison, was a skilled trauma surgeon, but his face showed the strain of dealing with an injury he'd only seen in textbooks. We're losing him. Brennan was still in Bay 1 with David, elbow deep in an abdominal repair that couldn't be abandoned. Dr. Morrison looked around frantically for help that wasn't coming fast enough. Marcus stood frozen for 3 seconds, torn between two worlds. His carefully constructed new identity, his chance to leave the past behind, his desire to just be a normal resident learning civilian medicine. And then there was the soldier dying 30 feet away. Pat saw the war playing out on Marcus's face. Go, the older nurse said quietly. He needs you. Marcus moved, not the careful differential walk of a first-year resident, but the purposeful stride of a combat surgeon who'd made life-and-death decisions in conditions that would break most people. He pushed through the crowd around Bay 3. The patient was a staff sergeant, maybe 30 years old, his chest rising and falling in rapid, shallow movements. The monitor showed all the classic signs: elevated central venous pressure, muffled heart sounds, distended neck veins, Beck's triad of cardiac tamponade. Dr. Morrison looked up as Marcus arrived. Thompson, you shouldn't be. We need someone with experience. I can do this. Marcus's voice was steady, calm, absolutely certain. Pericardiocentesis. I need a pericardiocentesis kit. Ultrasound if we have it, or we go blind if we don't. You've never done one outside of simulation. Dr. Morrison was pulling on gloves, preparing to attempt the procedure himself. I haven't either, not on a live patient. I've done 23. Marcus said it quietly, but every person in the immediate vicinity heard. In field hospitals, under mortar fire, without ultrasound, this patient has maybe 4 minutes before his heart stops completely. Let me work. The authority in his voice, the absolute confidence, made Dr. Morrison step aside, almost without realizing he was doing it. Do it. Marcus's hands moved to position the patient, prepping the subxiphoid approach. He closed his eyes for 2 seconds, visualizing the anatomy. Pericardiocentesis kit. Pat handed it to him. Their movements synchronized like they'd worked together for years instead of hours. Needle going in. Marcus's voice was quiet, almost meditative. 45-degree angle, aimed at the left shoulder. He advanced the needle slowly, carefully, feeling for the resistance change that would tell him he'd entered the pericardial space. The room held its breath. The monitor showed the patient's blood pressure dropping further. 70/40, 65/35. There. Marcus felt the needle penetrate the pericardium. Dark blood began flowing back through the syringe, evacuating fluid. He drew back 60 ml of blood-tinged fluid, and the effect was immediate. The patient's blood pressure began to rise. His heart, no longer compressed by accumulated fluid, could beat effectively again. Cardiac output restoring. The anesthesiologist, watching the monitors, called out, "Blood pressure rising, 80/50, 90/55. Marcus secured the catheter in place. He needs surgery to repair the cardiac injury, but he's stable enough for transport to the OR now. He looked up and saw Dr. Brennan standing at the edge of Bay 3. He'd left David to close the abdominal case and had witnessed the entire procedure. His expression was unreadable behind his surgical mask, but his eyes were sharp, calculating. Before anyone could speak, the bay doors burst open again. The last ambulance had arrived, and the paramedics were moving fast, their faces grim. "Critical patient, multiple injuries including chest trauma. This is Colonel James Rodriguez requesting immediate surgical intervention." The gurney rolled past, and Marcus saw the patient clearly. His breath caught in his throat. He knew that face. Had operated on him before in a field hospital outside Kandahar, had saved his life when an IED took out his convoy, and he'd been the only survivor because Marcus had refused to give up when everyone else said he was too far gone. Rodriguez was semi-conscious, his eyes tracking movement. When they landed on Marcus, they focused with sudden clarity. "Major Thompson." His voice was weak but absolutely certain. "Best combat surgeon I ever saw. Saved my life. Kandahar 2021. The emergency department didn't go completely silent. There were still too many active traumas being managed, but everyone within earshot stopped what they were doing. Pat, Dr. Morrison, the nurses, the residents who'd gathered to watch, and Dr. Brennan, who took 2 steps forward, his eyes moving from Rodriguez to Marcus and back again. "Colonel." Marcus's voice was steady, but something in his posture had changed. Like a weight he'd been carrying was finally about to be set down. "We need to get you stabilized. You're here." Rodriguez tried to smile through his pain. "Knew you got out, made it home. Good." His monitor began alarming, blood pressure dropping, 85/50, 75/45. "He's decompensating." Dr. Morrison moved forward. "Internal bleeding, probably from the chest trauma. We need to get him to OR immediately." "He won't survive transport." Marcus said it quietly, but with absolute certainty. "Look at his pressure. He's bleeding into his chest cavity fast. Maybe a shifted shrapnel fragment from his previous injury. He needs an emergency thoracotomy here. Now." Brennan moved closer, his eyes never leaving Marcus's face. "Field thoracotomy. That's not a procedure we do in civilian emergency departments." "I know." Marcus met his gaze steadily, and in that moment his carefully maintained facade finally cracked. "But it's what he needs to survive, and I've done 23 of them." The moment stretched out, balanced on a knife's edge. Then Brennan gave a single, sharp nod. "Dr. Thompson," he said formally, "show us what you can do." Marcus stepped to the head of the bay, his entire demeanor transforming. The quiet, differential first-year resident was gone, replaced by someone who carried the weight of command like a familiar coat. "I need a thoracotomy tray, 2 units O-negative blood, and everyone not essential to this procedure needs to step back and give us room." The nurses moved instantly, responding to the authority in his voice. Pat wheeled over the equipment cart while another nurse ran for the blood. The residents who'd gathered to watch pressed against the walls, creating space. Rodriguez's blood pressure continued dropping. 65/40. His breathing was rapid and shallow, his skin taking on a grayish pallor. "Major Marcus Thompson." He said it clearly, his voice carrying across the bay. "MD, United States Army Medical Corps. 4 years active duty, 3 combat deployments. Afghanistan, Syria, Horn of Africa." Emergency department fell quieter, conversations stopping mid-sentence. David Webb stood frozen in the entrance to Bay 1. Jennifer Park's hands stilled on the instrument tray she'd been organizing. Even the attending physicians turned to listen. Brennan's expression was unreadable. "You lied on your application." Marcus pulled on sterile gloves, his movements crisp and efficient. "No, sir. I listed my medical experience. Stanford for undergraduate and medical school. Army Medical Corps for surgical residency. It was all there. You assumed Stanford was my only training." "Military residency." Brennan's voice was tight. "You completed a full cardiothoracic residency in the Army. 3 years, forward surgical teams, over 340 combat surgeries, cardiac trauma, vascular repair, thoracic reconstruction, under fire." Marcus positioned himself at Rodriguez's left side. Betadine prep, no time for a full, sterile field. A nurse swabbed the colonel's chest while Marcus assessed the situation with clinical precision. "BP 60/35 and falling. We're losing him." "That's impossible." David's voice came from across the room. "You're 29 years old. That timeline doesn't work." Marcus didn't look up. "Entered medical school at 19, graduated at 23. The Army accelerates surgical training in combat zones. You learn fast because people die if you don't." He picked up the scalpel. "Are we going to debate my credentials, or are we going to save Colonel Rodriguez's life?" Brennan moved closer, taking a position where he could observe. "Proceed, Major Thompson." The title felt strange and right at the same time. Marcus took one breath to center himself, then began. "Left anterolateral thoracotomy, 5th intercostal space." His scalpel moved in a single smooth motion, opening skin and subcutaneous tissue. The incision was bold, confident, the kind you made when seconds mattered and hesitation could be fatal. "Rib spreader." Pat handed it to him, and Marcus positioned it quickly, cranking it open to expose the chest cavity. The ribs separated with a sound that made several observers wince, but Marcus's face remained focused, calm. "Suction." Blood welled up from inside the chest, and he cleared it systematically. "There. I can see the bleeding, intercostal artery laceration, and..." He paused, peering deeper. "There. Shrapnel fragment against the left atrium, old injury that shifted from the impact." "From Kandahar." Rodriguez managed to whisper. "Never got it all out. Too deep." "I remember." Marcus's voice softened for just a moment. "You told me to leave it, that you'd rather take your chances than have me dig around your heart in a field hospital. Looks like that decision just caught up to you." "Can you remove it?" Brennan asked quietly. "I have to. If it stays there, it'll eventually pierce the atrium. But if I'm not careful removing it, it'll tear the tissue and he'll bleed out in seconds." Marcus extended his hand. "Vascular clamps. I need to isolate the intercostal artery first." His hands moved with absolute precision, placing clamps to control the arterial bleeding. The well of blood slowed, stopped, clamped. Now for the critical part. The fragment was barely visible, a dark metallic sliver pressed against the thin wall of the heart's left atrium. One wrong move, one slip, and it would tear through tissue that couldn't be easily repaired. The room was absolutely silent, except for the beeping of monitors and the hiss of the ventilator. Marcus reached in with long forceps, his movement slow and deliberate. His fingers, his hands, his entire body was still, focused on that single point of contact. He'd done this before, in conditions far worse than this, in a tent that shook with each explosion, with inadequate lighting and instruments that were clean but not sterile, with 3 other patients waiting and no backup coming. This, by comparison, was almost easy. The fragment shifted slightly as he gripped it. He paused, adjusted his angle, pulled with steady, even pressure. The metal slid free. The atrial wall remained intact. "Fragment out, atrium intact." He dropped the shrapnel into a metal pan with a clink that sounded impossibly loud. "Now, suturing the intercostal artery, 5-deniroproline running stitch." His fingers flew through the repair, each stitch placed with mechanical precision. The artery was small, delicate, and the tissue was damaged from the initial trauma. But Marcus's hands knew exactly how much tension to apply, exactly where each needle had to pass. Arterial repair complete. He released the vascular clamp carefully. No bleeding, we're good. But even as he said it, Rodriguez's monitor began alarming. The steady beep of his heartbeat dissolved into the chaotic tone of ventricular fibrillation. "V-fib!" Pat called out. "He's arresting!" Marcus didn't hesitate. "Internal cardiac massage. My hands are already in there." He positioned his left hand around Rodriguez's heart, feeling it quiver uselessly under his fingers. 1, 2, 3, 4. He compressed rhythmically, manually pumping blood through his body. 5, 6, 7, 8. 1 milligram epiavar push. He kept compressing, his voice steady despite the desperate nature of what he was doing. "Come on, James. You survived an IED strike in Kandahar. You're not dying in a Boston emergency room." The epinephrine went in. Marcus continued the internal compressions. 30 seconds, 45. His shoulder was beginning to burn from the awkward angle, but his rhythm never faltered. 1, 2, 3, 4. 90 seconds of internal cardiac massage. David, watching from the doorway, had stopped breathing. Jennifer Park's hand was pressed against her mouth. Brennan stood absolutely still, his experienced eyes taking in every detail of the procedure. Then the monitor caught a single organized beat, then another. The chaotic tone resolved into the steady beep of normal sinus rhythm. "Sinus rhythm." Pat's voice was tight with emotion. "We have pulse, blood pressure rising, 90/60, 100/65. Rodriguez's eyes fluttered open, focusing on Marcus with surprising clarity. "Told them. Best surgeon I ever saw." Marcus felt something crack open in his chest. Some wall he'd built to keep his military life separate from his civilian one. "You're going to be fine, Colonel. But you're getting a full cardiac workup after this, and we're making absolutely sure there are no other souvenirs from Afghanistan hiding in there." He began closing the thoracotomy, his hands steady despite the adrenaline that had to be flooding his system. Chest tube placement, then closing in layers. Brennan moved to the opposite side of the table, observing his closure technique with professional interest. "That was extraordinary." His voice was quiet, meant only for his ears. "In 30 years of cardiac surgery, I've never seen anything like that. The precision, the speed, the decision-making under that kind of pressure." Marcus looked up, meeting his eyes across Rodriguez's chest. "It's what I was trained for, Dr. Brennan, but it's also why I came here. I wanted to learn civilian medicine, to save people without having to choose who lives and who dies based on available resources, to work in an environment where we have time and equipment and backup. And yet, you were willing to pretend to be a first year, to start over from the beginning." I needed to. Marcus returned his attention to his sutures, because the person who did those 340 combat surgeries isn't who I want to be anymore. He's someone I left behind, or tried to. The conference room on the 5th floor felt too small for the weight of the conversation happening inside it. Marcus sat in a chair that seemed designed to be uncomfortable, still wearing scrubs that bore traces of Colonel Rodriguez's blood. The clock on the wall showed 8:43 p.m. It had been 4 hours since the mass casualty incident began, and all 5 critical patients were now stable, in surgery, or recovering. Across the polished table sat Dr. Brennan, Dr. Patricia Holloway, who chaired the hospital's surgery department, and 2 members of the medical board. The silence stretched for several seconds before Brennan finally spoke. "Dr. Thompson." He paused, then corrected himself. "Major Thompson, I owe you an apology." Marcus's hands were folded in his lap, his posture straight despite his exhaustion. "Sir, I understand if there are consequences for not being fully transparent about my background." "Consequences?" Dr. Holloway leaned forward, her sharp eyes studying Marcus's face. "You saved 5 lives today. One of them with a procedure I wouldn't have attempted, and I've been practicing trauma surgery for 20 years. The only consequence is that we severely underestimated you. We all did." Brennan removed his glasses, cleaning them with deliberate care. "Your file showed military service, but nothing indicating the level of expertise you demonstrated today. The internal cardioversion this morning, the pericardiocentesis, the field thoracotomy, these aren't procedures you learned from textbooks." Marcus met his gaze steadily. "I didn't hide my military service. I listed Army Medical Corps surgical residency completed in forward operating bases. It was all documented in my application, but I understand why you assumed it was supplementary training rather than primary. You let us think you were inexperienced." One of the board members, Dr. Robert Chen, tapped his pen against his notepad. "Why? Why come here as a first year when you clearly have more practical experience than most of our senior residents?" Marcus was quiet for a moment, choosing his words carefully. "Because I wanted to learn civilian medicine, not as an addition to military training, but as a different way of thinking. Combat surgery is about triage, about doing the most good with limited resources. It's about accepting that you can't save everyone and making peace with that." His voice tightened slightly. "I wanted to work in an environment where we don't have to make those choices, where we have time, equipment, backup, where every patient gets the care they need, not just the care we can provide in the moment." "That's admirable." Dr. Holloway made a note on her tablet. "But it doesn't explain why you were willing to start over, to be treated as someone with no experience." "Because I wanted to be someone with no experience." Marcus's hands tightened in his lap, the only visible sign of his emotional state. "The person who did those 340 combat surgeries carries things I'd rather leave behind." "What things?" Brennan asked gently. Marcus closed his eyes briefly. "In Kandahar 2021, our field hospital was overrun during a major offensive. We had 17 critically wounded soldiers and limited blood supply. I had to choose." He opened his eyes and the pain in them was raw. 3 soldiers died because I made the wrong choice about who got transfusions. The inquiry cleared me, said I followed proper triage protocols, but that doesn't change the fact that I chose wrong." The room was silent. Even Dr. Chen had stopped tapping his pen. "I came here because I wanted to save everyone." Marcus's voice was barely above a whisper. "I wanted to work in a place where nobody has to die because we ran out of blood or time or options. I wanted to be a doctor who heals, not a soldier who triages." Brennan exchanged a glance with Dr. Holloway. Then he pulled a folder from his briefcase and slid it across the table. "Then you should know something. Colonel Rodriguez asked me to give you this. He's been trying to reach you for 2 months, but you changed your contact information when you left the service." Marcus opened the folder with trembling hands. Inside was a declassified Army investigation report stamped with official seals and signatures. His eyes scanned the pages, widening as he read. "The blood supply issue at Kandahar wasn't random," Brennan said quietly. "According to that investigation, which was only completed 6 months ago, the supply officer was stealing blood products and selling them on the black market. You were systematically shorted on every major trauma day for 3 months. The soldiers who died, they died because someone stole their chance at survival, not because you made the wrong choice." Marcus read through the document twice, his hands shaking. The words blurred together. Criminal charges filed. Court-martial proceedings. Guilty on all counts. Formal exoneration of Major Marcus Thompson, who acted with exemplary judgment under impossible circumstances deliberately created by supply chain corruption. He set the papers down carefully, as if they might shatter. Years of guilt, of second-guessing every decision, of wondering if he could have saved those 3 men if he'd just been better, faster, smarter. And all along, it wasn't his fault. It was sabotage. The room waited while he processed this. A tear tracked down his cheek, and he wiped it away almost angrily. Dr. Holloway spoke into the silence. "We have a proposal for you. We want to offer you advanced standing in our residency program. Your combat experience counts as equivalent to 2 years of general surgery residency. We're placing you as a third-year cardiac surgery resident, effective immediately." Marcus looked up, surprised. "I came here to learn from the beginning, and you've proven you don't need to learn the basics." Brennan's voice was firm but not unkind. "You need to learn how we apply those skills in a civilian context. You need to understand our protocols, our resources, our different kind of pressure. But we're not going to insult you by pretending you're a first year when you have more trauma experience than most of our attending physicians. Additionally," Dr. Holloway continued, "we want you to develop a combat to civilian trauma protocol program. Teach what you know. Help us incorporate military field techniques that could save lives here. Too many excellent military medical professionals struggle to transition to civilian practice because we don't value their experience appropriately." Marcus sat back, overwhelmed. I don't know what to say." "Say yes." A new voice came from the doorway. Colonel Rodriguez stood there, leaning heavily on a walker, his chest wrapped in bandages, but his eyes clear and determined. "Say yes. Because what you know shouldn't be wasted. You saved my life twice, Major, once in Kandahar and once today. How many other people could you save if you stopped hiding?" Marcus stood, professional courtesy overriding his emotional state. "Colonel, you should be in recovery." "I will be." Rodriguez moved slowly into the room. "But first, I needed to make sure you got that report, and to tell you something I should have said 3 years ago. What happened in Kandahar wasn't your fault. It was never your fault, and it's time you stopped punishing yourself for someone else's crime." The words hit Marcus like a physical blow. He'd been carrying that guilt for so long, it had become part of his identity. The surgeon who failed, the officer who made the wrong call. Letting it go felt dangerous, like losing a piece of himself. But maybe that was the point. Maybe that was exactly the piece he needed to lose. He turned back to Brennan and Dr. Holloway. "I accept the advanced standing and the program development, but I have 3 conditions." Dr. Holloway smiled slightly. "Name them." 1. Any veteran who wants to transition to civilian medicine comes through this program. We train them properly, help them adapt, but we respect what they already know. 2. We establish veteran-specific support services, PTSD counseling, peer groups, transition assistance. Combat surgeons carry trauma that civilians don't fully understand. 3. This is a 2-way exchange. Military medical professionals teach us, and we teach them. We learn from each other. Brennan nodded slowly. "Done. All 3. When can you start?" Marcus glanced at the clock. "It's 9:15 p.m. I start tomorrow, as a third-year resident." "You start now." Dr. Holloway stood, extending her hand. "Welcome to the senior surgical staff, Dr. Thompson. We're lucky to have you." 6 weeks later, Boston General Medical Center looked the same from the outside, but inside everything had changed. The simulation lab on the 3rd floor was packed with residents on a cold December morning. 12 surgical residents ranging from 1st to 3rd year stood around training stations while Marcus moved between them, observing, correcting, teaching. 6 weeks had transformed not just his role, but the entire culture of Boston General's surgical program. Today we're covering emergency pericardiocentesis. Marcus stood at the demonstration table, a training mannequin positioned before him. Civilian protocols emphasize ultrasound guidance, which is absolutely the gold standard when you have time and equipment. But combat medicine taught me that sometimes you have 60 seconds and no imaging. You need to know both approaches. A first-year resident, the same Lisa Chen who defended Marcus in the lounge weeks ago, raised her hand. "Dr. Thompson, what if we make a mistake going in blind?" Marcus's expression softened. You will make mistakes. I have. The question isn't if you'll make errors. It's how you prepare so thoroughly that errors become rare, and how you develop the judgment to know when to act despite the risk. He demonstrated the landmark technique on the mannequin. Sometimes the choice isn't between perfect execution and mistake. It's between attempting a difficult procedure or watching someone die. That's the reality of emergency medicine. He worked through the demonstration, his hands steady and sure, explaining each step with the clarity of someone who'd not only performed the procedure, but taught it under impossible conditions. The residents watched with an attention that went beyond academic interest. They were watching someone who'd proven himself under the worst circumstances imaginable. David Webb stood at the back of the group, his posture different than it had been 6 weeks ago. The arrogance was still there. That was part of who he was. But it was tempered now with genuine respect. When Marcus finished the demonstration, he was the first to ask a question. "Dr. Thompson, in the field, how did you manage the psychological pressure of making life or death decisions that quickly?" Marcus paused, considering the question seriously. You accept that you can't control everything. You train until the technical aspects are automatic, so your mind is free to focus on judgment, and you build a team you trust absolutely, because no one does this alone. He looked around at the faces watching him. That's true in combat medicine, and it's true here. We save lives together. Down the hall in his small office, photos and notes covered one wall. Harold Chen, the valve replacement patient from that first dramatic day, had sent a picture of himself with his 3 grandchildren, all of them wearing matching surgical masks as a joke. His recovery had been perfect, and he'd written to thank Marcus for not giving up when his heart had crashed. The soldiers from the mass casualty incident had all survived. 2 had already been discharged. The others were in various stages of recovery, and several had stopped by to thank the surgical team personally. And Colonel Rodriguez, fully recovered, had become an unofficial ambassador for the veteran transition program Marcus had developed. He'd spoken at 2 medical conferences already, advocating for recognition of military medical training in civilian contexts. Pat O'Connor appeared in the doorway carrying 2 cups of coffee. "Thought you could use this." The senior nurse had become Marcus's closest ally, the bridge between military and civilian medical culture that made the transition program work. "Thanks." Marcus accepted the cup gratefully. "How's our newest recruit doing?" "Captain Sarah Martinez?" Pat smiled. "She's adapting well. Little overwhelmed by how much time we have for each patient compared to field hospitals, but she's brilliant in trauma. Started her 2nd week as a 2nd-year resident yesterday." That's 7 veterans now in the program. Marcus looked at the organizational chart on his wall, each name representing a military medical professional who'd been given a genuine pathway into civilian medicine. 7 people who might have struggled to find their place, now thriving. 8, actually, Pat corrected. Got another application this morning, Navy corpsman, specialized in battlefield triage, wants to transition to emergency medicine. Marcus made a note. Set up an interview, and make sure he knows about the PTSD support groups. Transition is about more than just medical skills. His phone buzzed with a message from Dr. Brennan. Board meeting in 20 minutes. Budget approval for program expansion. He'd presented the proposal 2 weeks ago, expand the Veteran Medical Transition Program, establish formal partnerships with 3 other hospitals, create a certification pathway that would be recognized nationally. The statistics supported it. Trauma survival rates at Boston General had improved 23% since implementing combat-derived protocols. 7 veterans had successfully transitioned into residency programs. The model was working. The board meeting was efficient and positive. The expansion was approved with full funding. Marcus would direct the program while completing his own residency, a dual role that would have been impossible if he hadn't already proven his capabilities so dramatically. By the time he returned to his office, it was nearly 5 p.m. He had 30 minutes before evening rounds, time he usually spent reviewing cases or updating program documentation. Instead, he found himself standing at the window, looking out over the Boston skyline as early winter darkness settled in. His phone buzzed again. A text from David. Need consult on complex cardiac case. Your expertise requested. 6 weeks ago, he'd laughed at Marcus's suturing technique. Now he sought his expertise on difficult cases. The transformation wasn't just his, it was systemic. Another message, this one from Jennifer Park, Veteran Transition Program featured in Journal of Trauma Surgery. They want to interview you. Marcus smiled slightly. The program was gaining recognition beyond Boston General Medical Center. Other hospitals were reaching out, asking how to implement similar initiatives. The Department of Defense Medical Corps had contacted him about designing a national curriculum for military to civilian surgical transition. The scope of impact was growing exponentially. What had started as one surgeon trying to hide from his past had become a movement to honor and utilize the expertise of military medical professionals nationwide. A soft knock on his doorframe made him turn. Dr. Brennan stood there, his expression thoughtful. Thought you'd want to know. He entered, closing the door behind him. Department of Defense called. They want you to direct their National Transition Program. Full-time position, significant funding, chance to implement this across every major medical center in the country. Marcus absorbed this. That would mean leaving the residency program. You've already completed more surgical procedures than most attendings. Brennan sat in the chair across from his desk. The residency is a formality at this point. But the choice is yours. You can finish here, become an attending at Boston General, continue the program on a smaller scale, or you can take this national, change the entire system. It wasn't really a choice. Marcus had learned through pain and loss and hard-won wisdom that some responsibilities couldn't be ignored. There were hundreds, maybe thousands of military medical professionals struggling to transition to civilian practice, carrying guilt like he had, undervalued and underutilized. He had the knowledge and platform to help them. When would they need an answer? End of the week. Brennan studied his face. For what it's worth, I think you should take it. What you've built here in 6 weeks is remarkable. Imagine what you could do with real resources and national scope. Marcus looked at the photos on his wall. The patients saved. The veterans helped. The protocols implemented. This was just the beginning. I'll take it. The words came easily, feeling right in a way few decisions in his life had. But I want to maintain a connection here. Guest lectures. Consultation on complex cases, continued collaboration with the program. Done. Brennan stood, extending his hand. It's been an honor working with you, Major Thompson. This hospital is better because you were here. After he left, Marcus sat in the quiet office as darkness fell completely outside. In 6 months, he'd gone from hiding his identity to embracing it fully, from trying to forget his military experience to using it to help others, from carrying guilt for deaths he couldn't prevent to saving lives he was uniquely qualified to save. His pager went off. Trauma alert. All available surgical staff. Marcus grabbed his white coat and headed for the emergency department. His stride confident and purposeful. There would always be another emergency, another patient who needed exactly the skills he possessed. And now, thanks to the program he'd built, there would be others like him. Veterans who'd served in impossible circumstances, learned under fire, and brought those hard-won skills home. The ED doors opened and he stepped into controlled chaos. A patient on a gurney, nurses moving efficiently, residents responding to commands. This was where he belonged. Not hiding from his past, but integrating it into his present. Not pretending to be someone he wasn't, but being exactly who years of training and experience had made him. "Dr. Thompson!" the trauma attending called out. "We need you here." If you found Marcus's story of courage and transformation meaningful, consider how many veterans struggle to transition their hard-won skills into civilian life. Share this story with someone who needs to hear it, or support organizations that help military medical professionals find their place in civilian healthcare. Every veteran's expertise is valuable. They just need the right opportunity to shine.